Am I audible? Thank you.
Yes, sir, you're audible.
Check, check.
சரி ஓகே நீங்க ஸ்டார்ட் பண்றீங்க.
Good evening, distinguished colleagues and esteemed medical educators. Myself, Dr. R. Rajalakshmi and Dr. Ram Shankar, on behalf of the organizing team of the Golden Jubilee celebration of the National Teachers Training Center, NTTC, Department of Medical Education, JIPMA, Puducherry, presently led by Professor Jaiprakash Rajan, welcome you all to this landmark event. Today, we gather to celebrate the inaugural academic event marking the beginning of the Golden Jubilee celebrations of NTTC, a journey that will culminate in Medicon 2026 conference, signifying 5 decades of unwavering commitment to advancing medical education and faculty development in India. Before we begin, a few requests for our virtual gathering. Please keep your microphones muted except when speaking. Please use the chat function to post any questions during the presentation. We will have a dedicated question and answer session at the end of the webinar, during which your queries will be addressed. This webinar will be recorded and used for academic purposes only. As this is the inaugural event of our Golden Jubilee celebration, it is only fitting that we begin with words of wisdom from our esteemed director, Dr. Negi is a clinician par excellence, an academic visionary, and a deeply committed to the cause of medical education. In recognition of his outstanding contributions to the field of medicine, he was conferred the prestigious Dr. P.C. Roy National Award in 2017, one of the highest honors bestowed upon medical professionals in India. Under his dynamic leadership, JIPMA continues to uphold its legacy as an institute of national importance, fostering excellence, innovation, and compassion in patient care, research, excellence, and education. His unwavering encouragement and steadfast support to the National Teachers Training Center has been instrumental in strengthening the faculty development movement across the country. However, due to unavoidable official commitments, our director could not be with us today. He has, however, conveyed his greetings and best wishes for the success of this inaugural event. Over to you, sir. Ram Shankar. So you're muted, sir. Can you unmute? So you're still not audible.
All right. Am I audible now?
Yes, sir. You're audible.
Now it's a great privilege for me to introduce our inaugural speaker, Professor Emeritus Dr. K.R. Sethuraman, a name that is synonymous with NTTC itself. Professor Sethuraman was one among the pioneers who helped to lay the very foundation of this institution. Serving for 20 years, that's from 1986 to 2006, including a decade as a project officer from 1996 to 2006, he just didn't witness the NTTC's growth. He shaped it, he nurtured it, and helped to establish it as a beacon of medical education in India. The selection of Professor Sethuraman to deliver its inaugural address is not a mere coincidence. His career beautifully embodies the mission of NTTC to create not just competent teachers but compassionate educators who transform lives. From JIPMA to leadership role at AIMST University, Malaysia, and then to Sri Balaji Vidyapeeth, and as an international advisor for Davidson's Medicine, his journey reflects an unwavering commitment to educational excellence with human touch. Today, we launch our Golden Jubilee celebrations, and Professor Sethuraman returns home to speak on compassionate pedagogy in critical junctures in medical education, a topic that captures the very essence of what NTTC has always stood for: education that heals, teachers who care, and a learning environment that nurtures both competence and compassion. Ladies and gentlemen, please join me in extending a warm and respectful welcome to one of NTTC's own, Emeritus Professor K.R. Sethuraman. Sir, we are deeply honored to have you with us. Over to you, sir.
Thank you. Thank you. Thanks a lot. Thank you very much, Professor Ram Shankar. It is nice to be back in my first alma mater. I had 4 alma maters. JIPMER is first and foremost, where I spent 40 years of my life, from 1966 to 2006. And I am very thankful to the director, Professor V.S. Negi, Dr. Jayaprakash, and Dr. Kadambari for making this happen. And also, I record my thanks to a National Teacher Training Center, which completed 50 years, and I have spent 20 years in that team of teachers who are working in NTTC. Many people joined. It's not only the pedagogy group, but we had other training programs. I remember in 2000 to 2004, before I left, we had 42 of the 100 staff that we had at that time in JIPMER. Near more than 40% were involved in one or other FDP. And it was a very productive journey, and also very lot of learning happened at that time. So I wish to share some of the thoughts with you today. And also in my other alma maters, the second, next one was in cardiology in Chitra Tirunal, so I don't have any much stories to share. But third one was in Ames University. Some staff from Ames are also attending this webinar today, past and present staff. And also the fourth one was Sri Balaji Vidyapith. So some anecdotes. Everything is anonymized and non-judgmental, so nobody needs to feel nervous whether anyone's secret will be told. No, nothing like that. This is just sharing experiences for learning purposes, fact finding and not fault finding. Okay, so with that, let me start the slide share with salutations. With salutations to 2 pioneers, Dr. D.B. Bisht, who was the last principal and the first director of JIPMER in the late 70s and in 1980. He was the founder of National Teacher Training Center in India at JIPMER in 1975. And he was instrumental in organizing the first course in March 76. They attended a regional teacher training center, 14-day training program in Pedagogy in Sri Lanka. That was arranged by WHO, and WHO sent resource persons to conduct the workshop for the first 3 or 4 NTTC workshops starting from March 76. So he nominated Dr. D.K. Srinivasa as the founding member because he attended the first course, and then he was made project officer, and he ran it from 1976 to 1996, 20 years. And then he handed over to me. Then I had the privilege of running it for 10 years. He retired as Dean of JIPMER in 1995 and was curriculum consultant for Rajiv Gandhi University in Karnataka till 2006. Unfortunately, he's got health issues and could not even present himself live, so on the Zoom screen. So what I did is I requested him for a message, which he was kind enough to give. In 200 words, he has summarized the story of NTTC. He says, it's very heartening to note mother NTTC set up at JIPMER by WHO in 75-76 has sustained for 50 years. It was a bold step by Professor D.B. Bisht to lead a 3-member team from JIPMER to represent India in the WHO workshop at medical education, on medical education held at RTTC in Peradenia. Under WHO sponsorship, the first NTTC was set up at JIPMER and whatever I said just now. And he says, I was fortunate to continue, join the first course, which used to be for 2 weeks then, when WHO sponsored experts used to conduct the courses. Then after his nomination, he says early experiences not very happy ones like the Rajalakshmi and all face today. Faculty staff today will not believe that we, the early entrants to medical education, had to face dismissive comments, snide remarks, and derisive looks in early years of its inception. However, in the last decade, last 5 decades, medical education has flourished and well established. Several centers of excellence have come up in India. It gives me a lot of satisfaction that every medical college now has a medical education unit, which was one of the goals of NTTC. I was there in the meeting in 1991. Dr. D.K. Srinivasa proposed to Medical Council and they laughed and said, no, in that case, we won't get any examiners. That was 35 years back. But the same NTT Medical Council and National Medical Commission now insist that every medical school must have a medical education unit, which is a very welcome change. So we took long, but we achieved our initial goals. And he concludes by saying, I understand Golden Jubilee is marked by a series of webinars to be followed by Medicon 26 in April 2026. Let me offer my best wishes for the coming event. So this, I'm very happy to present on behalf of him, and I hope he's seeing this on YouTube or Zoom screen. Thank you, Professor Srinivas, from all of us for your message. So now let me go on to the topic today, compassionate pedagogy at critical junctures in medical education. So initially, Dr. Kadambari suggested some other topic, but somehow I was not comfortable. Then when I got up 2 days later, suddenly it struck me that this should be the topic I speak. And this was done about 2 months back, I think. So I spent a lot of time preparatory reading, and I made about 20 revisions of the slides before it became satisfactory for me, because alma mater is a very exacting place, JIPMER, and I have to rise up to the occasion. Thank you. So there are 5 themes in the topic today. Firstly, compassion. What are its components? Everybody knows what is compassion, but what are the components and how can one cultivate it? And secondly, how to use it in pedagogy and its benefits and challenges in medical education. Third theme is critical junctures in medical education, where compassionate pedagogy helps a lot. And fourth is sense of coherence approach for holistic understanding and how it can help with compassionate pedagogic practice. And lastly, CP, compassionate pedagogy as advocacy for equity and justice in medical education. Because these are the themes, and I will please permit me to tell a lot of anonymous stories and anecdotes. Everything is real, and I personally experienced it, or I've heard it from the horse's mouth. Okay, so nothing is created with ChatGPT. Okay, including the slides. Even in Vedic times, people were aware Guru had to be benevolent, compassionate, beneficent, kind, and patient, and must show appreciation to their disciples. This is now called appreciative inquiry, by pedagogy, psychologists and all that. But it was stated in Sanatan Dharma and published in Benares Hindu University textbook, 1904. What is not compassion is easily perceived. So this is from an anecdote reported in BMJ, 1987. I have written in my diary. And Dr. Professor Ananthakrishnan has also done a role play of this. It must be there in NTTC somewhere. Otherwise, Unbergen can get it for you. Latecomers are like undescended testes, and it goes on and on. So this total lack of compassion, and today, of course, you can't do this, but this had happened in 1980s, mid-80s. I have seen another, this one, I have witnessed in JIPMER itself in 1970 when I was in first year or second year clinical MBBS. That is third or fourth year. Your diagnosis is cavity in the right lung. The cavity is in your brain, not in his lung. Final year MBBS student was scolded, and we were happy that we are junior students, so he didn't scold us. So this happened in 1970. And now onto the mathematical formula of compassion. Sympathy is feeling pity and sorrow for somebody else's misfortune. Empathy is understanding and sharing the feeling of the other person. And compassion is a deeper concern arising out of empathy and sympathy, but coupled with altruistic motivation to help. So it is the motivation and drive to take meaningful action to reduce suffering that actually defines compassion. So I've stated it as a mathematical formula for ease of understanding. Compassion is equal to sympathy plus empathy plus conative drive. So that raises a question, what is conative drive? What kind of drive is that? So I'll show us in a picture. Sympathy is feeling sorry. Empathy is shared feelings. I can understand how you must feel and all that. And whereas compassion is going forward to help. You need to move to a safe place. Let me help. So it is connected and action oriented. And that involves conative drive. And then how do we cultivate empathy and compassion? If you want, I want to teach students this. We have been showing in interns orientation workshop, Professor Geetanjali will remember. How will I feel if I were in this situation? That is empathy. And compassion is, what can I do to help? So these two self-reflective questions, if students consistently ask for 4 years, by the time they become interns, they'll be thoroughly compassionate to the patients. So now on to conative drive. Conative drive is goal-directed action. That is the essence of conative drive. It is a driving force that translates competence into performance. So taxonomy of conation is these 5. First, you have to perceive a situation that needs attention, then you focus on that and you engage with that situation, involve yourself in trying to mitigate the problem at hand. And when you do that, you get what they call as you are in zone or you are in flow, or you get a peak experience of dopamine secreting in your brain and making you feel happy and transcendent. So this is the essence of conative drive. And that is in CBME curriculum, actually, this is very important. Competence we can teach, do ASCII and certify them. But when they become doctors, do they perform when they are residents or interns? So effective conation reduces the competence performance gap. And they will not say, I can do, but I will not do. That is not non-conation. So people with conation can do and will do. And now let me link up compassionate pedagogy with conative drive, the elements. Compassionate pedagogy is defined as an educational approach that notices and actively addresses or mitigates distress and disadvantage in the learning environment. And it has a focus on student well-being and holistic student development. So let us see how the conative, the 5 elements which I put, they fit in beautifully. Perceive and focus is to notice. Engage and involve is mitigating student distress. And when the student holistically develops and you see in front, very compassionate product you can be proud of to call your student, that is transcendence, and you feel very happy. All of us have felt that at some time or other. So, unfortunately, Bloom's taxonomy sidestepped this conative element. They only concentrated on cognition, affective domain, cognitive domain, and psychomotor domain. And conation was sidestepped because they felt it is embedded in these things. But it is better to be explicit, especially if you are doing competency-based education, which has to translate to performance in real life. Is compassionate pedagogy important in medical education? Because we can understand it's very important in kindergarten and primary school. So why these adults studying medicine and UG, PG courses, why is it important? It's important for educational reasons of educational psychology. Several studies have shown that anxiety and distress compete with learning. Anxiety and distress compete with learning and ability to absorb and retain information. So the object of compassionate pedagogy is to reduce student anxiety and move them from distress, which affects learning, to eustress, which is a good stress, where peak attention and peak learning happens. And save them from a paradigm of suffering and distress to academic success and well-being of eustress. And it is not zero stress, understimulation. That is called euphoric lethargy. Euphoric lethargy will happen if there is no stress at all. In fact, I'll start the first story with that. In 1969, our batch faced pharmacology exam. Usually nobody fails. At the most, one person will fail. Nobody fails in the exam. But unfortunately, the professor who was teaching us, he had come from somewhere and he was an examiner from a university. So every time in every class, he will say, I am university examiner, don't worry, all of you are guaranteed pass and all that. So people really believed him and took it seriously and stopped studying. It went into euphoric lethargy. Only a few of us, some 10 or 15 of us, didn't take it seriously. Anyway, let us read. So we studied, and I think 15 or 20 of us, only minority of the batch passed. I think it was a record for 30, 40 years. It may still be the record. Maximum failures that happened in pharmacology was our batch, which wrote the first entrance exam. And I don't know, Geetanjali should tell me later whether it was broken at any time. And it was a very rude awakening for us. We didn't lose time, of course, because it could be carried. But it was a rude awakening that understimulation affects performance. After that, our batch woke up and we studied hard, regardless of whether it is a minor exam like ophthalmology or major exam like surgery. We took it seriously. So this eustress is a good place to be, and distress is not the place to be. Neither understimulation. Okay, so next is, Now let me move on to the second theme, critical juncture, next theme. So critical junctures in medical education are pivotal moments of significant change and stress. And at that period, because of stress, student learning will be impacted. We have seen that every batch in the first semester exam, I'm sure Professor Rajalakshmi will be seeing it even today, that a lot of failures happen in the first stage or first test that is done in first year MBBS because of this critical juncture that causes distress of various types. Leaving home, new place, a lot of things to study, a lot of Latin and Greek, so many things. So it's not only in India, all over the place. So these are critical junctures already reported in the West, US, Europe, and all that. Entry into medical school, facing high-stakes summative exams, moving to clinical settings, starting internship, starting PG residency, etc. In addition, this is for the whole group. In addition, there are individual pivotal moments in somebody's life, getting married or losing somebody near and dear, accidents. So things like that happen, financial difficulty. So we'll see some of that later, some of them. Compassionate understanding and guiding the students to navigate these moments of critical junctures is crucial for their success and well-being. So that is ideally a role of a mentor. Mentor-mentee relationship is meant for that, but how far it's functional in every college that is for us to introspect. So these are the common critical junctures for the whole group that is reported. And cadaver encounter. I remember our this thing, it took a few days to get used to that. And the desirable outcome. So the compassionate action is reflective, allow the students to reflect their fears, phobias, and all the other things. But you have rituals and make it part of, like respecting cadaver is a ritual. So things like that make it easier to traverse the journey instead of shaming the student. Not everybody has this critical juncture distress. Some of us have. And every year in the operating room, we see when a new batch comes in, the spurt of blood, one or two will faint. So that happens. So exam failure, resilience is needed, desirable outcome, and we have to support and have a recovery plan. I'll share some stories. Breaking bad news. The Spikes protocol is famous for that. Even talking to students, if they fail or if they're vulnerable, the Spikes protocol can be adopted as an empathic form of communication, and then plan how to rescue in a compassionate way. ICU rotation, mentoring and mindfulness. I remember a student, intern posted an ICU. We had only one single bed ICU those days in 1970s. And intern on the first day of medicine had a death there, and the guy was so in distress, he came running all the way. He was 2 years or 3 years junior to me. Came running from 44 ward all the way to Harvey House top floor, about 1 kilometer and about 7 minutes. And was breathless, and then says, patient has died. Patient has died. Patients, of course, if they are unfortunate, then they pass away despite the best treatment. But the first time his medical student has become an intern, and first day of posting, he faces this. He doesn't know what to do. So then I dressed up, went with him, did all the rituals and said, this will happen every other day in medicine ward. Don't worry. This is what you do and all that. So show emotional maturity and not laugh at them, but try to help them tide over the crisis. Then observing other unethical behavior, some staff shouting at subordinate staff and things like that. So we have to allow ethical dialogue and empowerment to report, and it needs desirable outcome is moral courage. So every juncture has a appropriate, compassionate, cognitive action that we can do as staff or mentors, and it has a desirable outcome for the students. When they become professionals, they'll have these positive, desirable outcomes. Okay, then how can we handle new students? Many colleges have now new student thing that is very desirable to make them join the mainstream, part of the mainstream. One thing they have to understand is the difference between school learning and college learning. That is where they struggle in the first exams in first MBBS. I used to summarize this. In schools, teachers chase the students and teach them. Whereas in colleges, teachers are busy with so many other things, patient care, research, and other things, priorities. So you have to chase them. don't think they'll come and attend to you and all that. So when I was dean in Malaysia, every year we have this orientation. So I used to tell them, don't expect us to chase you, you have to chase us. And second is remind them to believe in themselves, even though they have difficulty in year one, say that it becomes better by year 2 or year 3, so don't worry. We have all been there. And give them a sense of purpose. A sense of purpose can be abstract. I've seen a material sense of purpose in Malaysia. Generally, out of 100 students, 1 or 2 used to get a distinction. Overall average, if it is more than 75, we give a distinction, they are given MBBS honors. And that was only 1 or 2 because it didn't mean anything. All of them used to take government loan because I was in a private university. They used to take about 20 to 30 lakhs loan those days. And the government said, if students get distinction average, they'll write off the loan as scholarship. And after that, when I announced it to the new batch and said, you have to study hard, we'll help you. What happened is, we got a 10-fold increase. Instead of 1 or 2 students, it became 10 to 20 students every batch now get distinction. They study hard and they win, and they get a reward of about 30 lakhs converted from loan to scholarship. So like that, this for the college to give a sense of purpose in fee waiver or merit prizes or whatever. Okay, so compassionate pedagogy in a cadaver lab. That, of course, very obvious. I'm not going to spend time. Somebody has done a study and published it in 2020 February. Taliban University Medical Science. And when we give a feedback, there is one way, harsh way, which is not that compassionate. You pen all this drivel for pages and pages, wasting my time to assess this. In fact, we had an anatomy teacher who used to scold us saying that I am a tax-paying lecturer, and I am supporting your education, and this is how you repay me. I pay for your tuition, and you repay by writing all this nonsense. You owe me better and all. He used to make us feel guilty. So that is one way of doing. The other way is find something nice to. His handwriting is good, so he's taken that. Your handwriting is so nice. If the stuff that you write is as good as your style of writing, then you will get A, So matching the substance and style. You have style, get some substance too. So then he gets motivated. He might get motivated and he might ask, please tell me how to do better and all that. So that will be a part victory. Okay, now we move on to my diaries. I have a big collection from 1970 to 2023 when I retired from AIMS. This word I use as a tracking, as a tracer. When I meet students, I ask them, especially interns and all that, CRRIs. I'm a patient. I want to know what when you say you have a lesion in the liver, I ask you, what is a lesion, doctor? What will you tell? I'm yet to find a student who can actually say simply that it's focus of pathology. Every teacher in pathology and the other clinical subjects know lesion means focus of pathology. But do we ever care to explain when the first time lesion is mentioned, either in first year or second year? Do the educators take care? Because everybody assumes that everybody knows. This is called Dunning-Kruger teacher's fallacy. We assume that lesion is so common a word, everybody knows what it means, so we don't explain. So the student carries on for years without knowing what it really means. So when a patient asks what is lesion, you don't have to know all this. I'm the doctor, you are the patient, keep quiet. So otherwise change the doctor. They get angry because they can't answer. So if lesion is like that, what about the thousands of Latin and Greek that we unload them on during year 1, year 2, anatomy, physiology, biochem, and pathology and all that? Do we really care to explain or give them some room or a glossary or something to refer? Now, of course, Google is there, AI, but those days it was more difficult. So struggling students often feel stigmatized. So whenever a new word comes, I used to tell in the class that you stop me anytime you encounter a new word that you don't understand. Either I'll tell in the class or at the end you stay back, I'll explain to you. So, and struggling students often feel stigmatized because they are not at par with the rest of the gang. So my role model was Professor Ganesan, former dean in 70s and 80s in Manipal. And he used to come as an examiner. Yeah, he was a mentor for, he said, all the high achievers, you study by yourself, don't bother me. I will come and give you gold medal or whatever you get, certificate of merit. But people who need help come to my house. So his house was open. They can go and discuss any problem, financial, family, personal, any critical juncture in person or as a group they face, they used to go and ask him. So he used to, I was skilled assistant those days, helping in the exam, and when free time, lunchtime and all, he will share some stories. So I adopted him as my role model. And when I was PG resident and senior resident for 5 years, and later as faculty, I used to take special classes on how not to fail in theory, clinicals, and Viva. Students still remember those. The exam tips, how not to fail. Because failing in MBBS is very, very difficult. But the thing is, vulnerable students think it is very hard and they study intricacies of mitral stenosis, mitral regurgitation, try to mug up. Nobody fails because they tell a murmur, they can't identify a murmur. They fail because when we ask how many chambers in the heart, they'll say 3. Then medicine, most of the failures have been because they say right lung has 2 lobes only. They are very sure. Things like that. And heart has 3 chambers. How many valves? They'll say only 2 valves. But when does the valve open? So things like that. So how not to fail teaching is very easy. We have to put an examiner quote and say what are the fundamental facts that actually differentiate between borderline pass and failure. That is very easy to teach. I still have a fact sheet. There are only 43 basic facts in cardiology. If they know that, they can pass cardiology exam without failing. So I used to make sheets like that and give them. The only sheet that remains is cardiology. And for advanced learning, it is 63 or something, 60 odd facts. That's all they have to know. So I used to coach them individually. You just learn this. If you don't know the murmur, just say, I cannot perceive the murmur. Heart rate is fast or irregular or whatever reason. Examiners understand. Like that for theory, clinical, Viva, we have to take the effort to help them out. And for theory, writing as learning, you can look it up, Google search, WAL it's called, writing as learning principle. Exam questions attended as assignments, as an open book assignment. Then later closed book assignment, then they get confident. That always works. Many people don't believe, but even in Malaysia, we tried and pathology lady was so happy. So what are the benefits? Now let me move to the benefits. Enhanced student well-being and improved learning outcomes, stronger relationship, holistic development, preparation for professional practice later day, and reciprocal benefits. Reciprocal benefits means to the college and also to the teacher in terms of long-term relationship. I'll just show one example of one student from JIPMER 1996 batch and his teachers in medicine unit. So he was one of the people suffering from additional batch syndrome, neglected by the teachers because they are small in number, 4 or 5, and also because they are laggards and they call low achievers or poor learners or whatever, problem students. So many negative terms were given. And they neglect the studies and their teachers in return. The mutual neglect. But a positive example was Dr. Mukesh. He was also an additional batch, but some staff treated him as a genuine student with future potential. He got motivated, tried hard, and in spite of writing exams, he got being a supplementary badge. He scored distinction in medicine, and later joined the army and was in the Indian peacekeeping force, foreign assignments in Africa. And he has sent a Facebook message with a photograph to the department. I belong to 96 additional. I took his permission to show this. I got 75%, and most teachers hate additional batch, but you took great interest, etc. And got joined army in 2005, serving nation. Now he's left army as lieutenant colonel. He got promoted and retired as lieutenant colonel. I heard he's somewhere in Rajasthan. So that is what I mean by a long-term relationship and mutual regard for each other. So we have to help vulnerable students cope with the challenges, not to scorn or be judgmental, but to support with compassionate strategy, compassionate pedagogy. So understand their difficulties and advise coping strategy. This person is a preclinical professor now, was very forgetful and failed in final MBBS exam 35 years back, some mid-90s. Then used writing as learning, this technique, know what I said, WAL. And that time I didn't know that it was called by this name. Gave them fact sheets and basic facts for clinical exams, how not to fail, and built core knowledge with writing as learning. Then he passed. Then he specialized in a preclinical subject, and then now he is a professor of one of the preclinical subjects. And other students who failed lacked basic answering strategies for essay type question. So the study first, do open book exam as assignment, then closed book worked very well, both at JIPMAR, also at in Malaysia, where we tried. Special difficulties and blind spots. This is a little tricky problem. Just like people with physical challenges get admitted. We had a lady student walking in crutches who did MBBS in JIPMAR. So like that, there are some physically challenged ones. It's easy to, I think, in government supports. Unfortunately, there are non-governmental supported weaknesses in some. Student X had a auditory recognition problem. Otherwise, fine. Theory, very good. Practicals, very good. Inspection, very good. But audio recognition was very difficult. He couldn't differentiate heart murmur, lung sound, or anything. And he was very afraid of this thing. So what happened is, when you are a skilled assistant, you help him get a case that is not dependent on heart murmur or lung sound. You can always give an endocrine case or a CNS case or abdomen case or something. And that person became another professor in a subject which does not need a stethoscope. One became a professor of dermatology, the other one became a top surgeon in Malaysia. So, because he has to only know whether bowel sound is there or not. As a surgeon, he said, that much I can recognize. But if you ask me to identify a lung or heart, then I am blind, deaf to that, cannot recognize. So sometimes we get odd cases like that, and I don't know, we have to be ethical at the same time, we have to be compassionate. So I can't give more details than that. was a stammerer. Some of you might recognize him. He was in Japan, who couldn't speak full sentences, especially in Viva C when he is under stress. And so I remember requesting the external during lunch. He said, no problem, let him write and I will give him extra 10 minutes. So he was allowed to write all the answers and give it to them in the Viva OC, and he passed the exam. So if you seek the support of external examiner, they also see reason. Just because somebody stammers doesn't mean they have to fail in MBBS. So, but later, now the same person speaks without any stammering, absolutely specialized and a very successful practitioner. And so you will not, I mean, at least I can't recognize he was the person who had difficulty and we have to help him out. So now the other theme for critical juncture and practice of compassionate pedagogy, we need a holistic understanding of situation that students face. So for this, the sense of coherence model, a global orientation towards world and its global scenario. They say it has three components: sense of comprehension or understand what is happening, sense of manageability, how to cope with this situation, and out of the options, choose whatever is the most meaningful and to you or to the person, the student whom you are trying to help. I'll give an example. I didn't know the sense of coherence, but I did this over about 5 years, I think. Because as all of us early birds in JIPMER know, 70%, nearly 3/4 of the students in JIPMER do not know Tamil, local language. And they were practicing clinical postings like veterinary medicine, just prod and probe. No, they can't talk to the patients. That was a problem. So I tried motivating them why local language is important, because history gives 75% of the diagnostic clues. Had zero impact. Every year, 5 to 10 people will ask for language translators. Then what happened is I found some people who came from Hindi belt, they had made a small 16-page handout with Tamil pronunciation written in Hindi script with English meaning. So they used to use that, and by the time they came to final year, they were very comfortable talking to patients. So I got it, made a manual out of it, which upgraded version is even now available in JIPMER website. It has been much expanded, but its origin was in 1970s from the students. And learned Tamil through Hindi, and it was sold for 1 rupee through cooperative stores. It had a slight impact. They used to buy, but still, for safety's sake, they'll ask for nurses to be translators in the exam. Then I was at wit's end what to do. And this had already taken from 1982 or 83 to 1990. In 1990, I met two alumni. One said, one is my one went to France from Pondicherry. And then he thought that Tamil will be useless in Pondicherry virtually and all that. In France, in Paris. He was in Paris. But what happened is that time this war was going on Sri Lanka, and a lot of Sri Lankan Tamils went as political refugees to France. And they all ended up in some camps in and around Paris, about 100,000 of them. And they can talk only Tamil. They didn't know any other language. That was Ceylon version of Tamil. So then when they found out that there is one doctor who speaks Tamil, then my class fellow got all of them as clients. He was so busy managing them. So that was one story I got. The other one is from Northeast frontier, from Nagaland or somebody, we used to get 15 students from Northeast central government quota. So they used to go back to the rural places. So he thought it's meaningless to learn Tamil. He never learned. But when he went there, he found that Malabar Regiment and Madras Regiment was posted there for this border security duties. And once they knew somebody has come from Pondicherry, here of course they call it Madrasi. When Madrasi trained doctor has come, they assume that they will know Hindi, Tamil. So first day when he joined primary health center, he found 400 family members waiting there to see him. Then he felt very guilty and sheepish because he couldn't. He told me, sir, had I known, I would have learned properly. You gave the book and all that, but I didn't even buy a copy and all that. And only the words I learned was how to scold the mess boy and ask him to speed up serving the meals. So then I just requested him, can I share your story with the students so that they'll be motivated? So then they both agreed, and from 1990, I used to do this. I'll ask the students, you think it is a waste of time to learn local language? Then all of them will nod, yes, yes. Then I'll share these stories. This is what happened to a doctor who went to Paris, somebody like you, 30 years senior, and another guy, 10 years senior. He went and this is what he found. And do you think learning a language is waste? They'll say, no, no. Then how many are you willing to learn language? All of them will lift the hand. Then, okay, now the book is there, you buy and then try to learn. After that, you can check with the registrar or dean's office. From 1990 or 92 or something, nobody in final year has asked for, at least until 2006 when I left, nobody asked for a translator. That has stopped. That is my proof that this thing worked. So now I am able to relate that it was a sense of coherence. We understood the problem that local language is important, but it didn't work. Gave a coping strategy in form of a learn Tamil through Hindi small manual. That also had a limited impact, very little. But when meaningfulness was given, that there is a meaning to learning language, it's never a waste. Somewhere in the world it will come in handy. Then everybody adopted it. So as a teacher, as an educator, we have to learn to use critical thinking and broad global understanding of problem by using sense of comprehension, sense of manageability, and sense of meaningfulness, and transmit it to students effectively. Then it will be successful, like this particular one. I took a long time because a lot of youngsters attending the webinar. I'm sure you can use this in your own situation. The others will be faster. Then student diversity and inclusivity. Just two examples to share. 42-year-old PhD researcher joined medicine to get bullied by batchmates, half his age. So what do I do? From the batch, I took a peer referee who was acceptable to him, the elderly man. He's already done PhD in US and he had come to Malaysia to study. And said, okay, this man is your referee. Whatever is your problem, you tell him, he will handle. So the bully and the victims were separated, and over a period of time, they all became friends. I met some of them. They are very good friends now. Then this one will resonate because you had a similar situation when Ukraine war started. But unlike the totally negative reaction in India, in Malaysian government, what happened is numbers were small, about 400 candidates who went to Indonesia. There, the entry marks were very low. So those who don't get entry into MBBS in Malaysia, they used to go to Indonesia and join some of the colleges. And when the earthquake happened in Andalas, that Andalas University Malaysian students, they all came back to Malaysia and they didn't want to go back. But there was a negative reaction initially from some people, letters to the editor and all that. It's a foul method, ban backdoor entry into Malaysian colleges and all that. But medical council was supportive and minister was supportive. So we took 40 of them. We took 10% of the students, and to prevent this difference between our students, who are in it, and the people who came from Andala, we had arranged a welcome meeting and some performance by the Students' Council, art, dance, and song, and all that. And what turned the day was some students who were affected, who were in the earthquake zone. They had shot some videos on the mobile phone, so they shared it, the distress they faced and all that. And that had a total change in the theater from the initial hostile or disinterested. The minute she showed the video and tears poured from her eyes, everybody turned and became very supportive. They merged with the batch. They are all successful doctors in government service in Malaysia, and some of them have left and joined private also. Then what do you do with students with behavioral problem? You can label them as problem student and keep issuing memo, or you can try compassion and see if it works. I'll share a bike bully story. 2007, people were scared. One fellow had a 500cc bike and was very far, going very fast in the campus, and people used to run helter-skelter. And when I called him to my room, my PA advised, please don't engage with him. He's twice your size and very bully type of fellow and all that. I said, no, I just want to have a cup of tea with him, ask him to come. Then he came. I had 2 counseling sessions, non-judgmental, just listening to him. Finally, after 30 minutes first counseling, he started crying. Then he says he was a gold medalist in +2, but because of that, father gave him a 500cc bike, and then he became like this. He thought he is impressing girls. I told him, you are mistaken. Everyone is mortally afraid of you. Then he changed. He is a very successful practitioner. I met him 2 years in 2002, 2022, before I returned. The other one was much more problematic. If there is some student whom I really wanted to slap, she was the one. We used to always look at the empty part of the glass. Some staff is not there, so this is not there, that is not there. What is that? She will never tell. And the worst thing is, she'll keep writing notes to medical council that to come and inspect this university, useless place. Everybody is angry why they joined this place and all that. Then I tried counseling her, she won't listen. Then MMC inspectors came, Malaysian Medical Council. Then what I did is, instead of sending her own batch had very sober peer group. I took 4 more from that, 2 girls and 2 boys, and sent her and said, you listen to all 5 of them and make your decision. Then after listening to all the 5 individually, the inspectors actually counseled her. Every college has problem. You are just exaggerating everything. Learn to get on with it and all that. So they advised her and went. And then after that, she was still rabble-rousing, but not stopped writing to Malaysian Medical Council. But later, after she became doctor in government service, I met her one day. And she apologized, actually. She said, I'm very sorry I was like that. I realize now that I was behaving badly. Then she said, actually, her house scene was very bad. Father and mother were fighting every day. I think they're about to separate legally. And that was the reason why she couldn't do anything to them. So she took it on the poor medical school. All her anger she put on us. She realized it later and apologized. So I learned some lesson. Avoid any negative bias, however irritating or problematic student may appear to be, at least initially. I mean, at the same time, you have to prevent harm. If I had only sent her to MMC inspector, they would have written a bad note, closed down the college. But sending the peer group, which are sober, mitigated the thing. So it works both ways. We have to be a little compassionate to ourselves and our own institution also, not only to the student. Then now macro level example. no minimum score for continuous assessment for eligibility to certain summative exam. It looks very kind, but it is very disguised cruelty because 40% weightage is CA. If somebody scores only 5% in internal assessment, CA combined, then they have to get 45 out of 60 in the final exam to get 50%. Because 5 out of 40, and they have to get 50 to pass from the remaining 60 marks in the final exam. So that many people don't realize that it appears to be kind, but actually it is very cruel. It was a situation when I joined, and the curriculum was designed like that. So it was adopted from British curriculum. So I quickly changed it. The first thing I did in 2007 was to request Malaysian Medical Council to change. And eschew unwarranted rigor, insisting that even failure in one paper, they have to resit the exam for all the papers. They are vulnerable students. So why should we load them? We had an example like that. When first time they'll pass 4 out of 5 papers, second time they'll again pass 4 out of 5 papers. That means they passed all the papers once, and 3 papers out of 5 actually twice. And when I pointed this out in 2008, the council permitted, okay, let them supplementary exam, they'll only appear in the failed paper, not everything. So like that, we have to, step by step, I have to work for 4 years before the curriculum became a little compassionate towards students. And similarly, long case 50%, 3 short cases 50%. So if they do badly in long case, however well they do in short case, they cannot pass. That is how it was. So then I just requested 10% reduction, 40 in long case, 60 in 3 into 20, 60 in long case, short cases. Then after that, the failures became very negligible. From very high level came down to very low levels. So like that, we have to see macro level, not only individual student, macro level. Economic hardship is a reality. I appreciate the student, many compassionate staff who used to help them out, both in JIPMER and in Malaysia. They used to help to eat food or have something to go by. And one student I remember is a very good student, top 10 ranker all the time. I could keep him under finance office radar for 4 years. But when he came to final year, he had 20 lakhs due. Then I told him, my job is at risk, the call, so you better pay up, otherwise you can't write the exam. But I gave him a good recommendation letter. Based on that, somebody gave a short-term study loan just 3 months before the exam. He paid up, got the hall ticket, wrote the exam, passed. And then when he became intern, he got money. Malaysia pays good CRRI, just like JIPMER. So from the stipend, he started paying back the loan. So it's a success story. A very prosperous practitioner in neighborhood of Ames University. One of my favorite students. So we can help sometimes not by giving money, but finding some other solutions. Then non-registrable medical doctors, when they come, what do? You can say you deserve it and leave them alone. But 400 of them were like that, driving taxis or selling drugs as pharmacy representatives and all that. So medical council said, okay, lifeline of 3 more attempts, and along with final year exam students in any Malaysian medical college. So we took 40 of them again, 10%. And 2012. And I told, we had a novel experiment, collectively done by all the heads of department. And 70 hours per week, 7 months rescue plan. That's what we said. Others tried 3 months, 2 months and all that. And the national average was only 10% pass. So in fact, examiner said, if you have taken 40, you be happy if 4 of them get through. but 27 of them got through. I expected 25, they exceeded my expectation. 27 passed in the first round, 11 in the second round. Then what happened? If we had been in government college like JIPMER, we would have probably been cited for some national award. Unfortunately, it was private college, so it smelt of fish. I had anticipated this. So what we did is, I called my friend who's a national figure in government college in Malaysia. So he came as chief examiner. He went through the whole process. So he gave a certificate saying that he couldn't find any difference between these people and the regular students. We had also randomly mixed them up. So nobody could identify them as separate batch. So I learnt a hard lesson. You offer compassionate help, but be always above suspicion and safeguard your own image. Otherwise, we'll smell fishy. So based on this so many years, my list of 7 to be compassionate educator is: create a holding environment, be mindfully present and attentive to your own safety and to the safety of the students and your own institution. And of course, ethical self-test we put too. And I use a Solomon cap. Solomon cap is to look for win-win-win option. We should win, students should win, and the institution also should win. And it is possible if you use critical thinking and creative problem solving by asking what if and why not, and proactive thinking. And also, when you get into a leadership position like unit head or a departmental head or a institution head, then you have to see, am I a funnel type of leader or a umbrella type of leader? Funnel leader passes all the distress to the students. It doesn't take any ownership. Whereas umbrella leader tries to protect them. That is, you need compassionate pedagogy if you want to be an umbrella type compassionate leader rather than the funnel leader. This I picked up from business strategy and brought it to compassionate pedagogy. So it needs perception and courage to open your umbrella and protect the students. It's not that easy. This is a story from JIPMER only, because the minutes will be there in JIPMER office. A medicine MD was like Russian roulette. And because I used to notice a skilled assistant even in the 80s when I was a lecturer, day one long case people all passed, less than 10% failure. Whereas those who get short cases first day, half of them will fail. Those days only 3 or 6 will appear. So 4 students appear on first day, they all pass long case, 4 appear in short case, 2 of them will fail. And next day, second day, they are eager to go home, so nobody bothers. So everybody passes on second day. So ultimately, the unfortunate people who got short case, they are the ones who fail, and they'll never get gold medal. And when I initially told my colleagues, they never believed. Then I collected 10-year statistics and presented it in academic council. And then they agreed that it's a problem, and they were very gracious. I think Professor Subbarao was the dean at that time. Very gracious in accepting and recommending to Pondy University. That time it was in Pondy University, and then for medicine alone, they said all on day one everybody will do long case and everybody will do short cases on day 2. So this lucky draw Russian roulette type of thing went off. I don't know what happened after that. This was the thing from mid 90s to 2006 when I left. What do you do when you face a HOC examiner, hostile examiner? We had another case in JIPMER only, medicine examiner, who hated pretty girls, used to punish them badly. Whereas others who are plain looking, he was more considerate. How do you handle this? So I was caught off guard when I saw this first. I was skilled assistant then. Then later I used to tell the batch to call everybody and say, dress up shabbily and come, don't be in a pretty mode. Once you give a hint to the girls, they know how to look good and how not to look good. So they somehow used to make themselves very plain and ordinary, and then this Professor A was not unkind to them. So sometimes you have to give a lead like this. And in Malaysia, I faced a doctor specialist who was biased against non-Chinese because she felt they don't study well. Then what do you do? And another person who was against, biased negatively against foreign trained medicos, he won't even listen to them. There are good students who study in China, Russia, Ukraine, and all that, but biased. What do you do? If you want to know, I'll tell you later, because I don't want to go on record on this. Okay. And a commitment to whatever I did was for fighting for justice, and it was fair play and ethical. And we have to go beyond equity. So when you want to go beyond equity, this diagram is the best. Inequality exists in all spheres, including in medical education. Equality means giving equal boost to all students. That doesn't really help. Equity means vulnerable students are given more help. That helps a lot. But even better is, when possible, go for justice. So the curricular corrections which I mentioned is all fighting for justice. Asking all MD students to appear on long case on day one was like this. Change the system. Instead of trying to say this one, go for justice. So make the tree flat so that with equal access, both of them, everybody is equal. So you have to, compassion means striving for equity and going beyond equity to justice wherever possible. So that is what we have to do. And sometimes it needs courage to face up to martinets. Martinet is someone who is superior to you and demands exact conformity to rules. I had a PG resident who had to take 6 months leave of absence in a calendar year. But it was, if you take academic year, 3 months in year 2 and 3 months in year 2. So it's a question of interpretation. But the deanery said 50% attendance must be made up, and informed the university not to issue hall ticket. And department faculty said 30 out of 36 months posting is actually more than 80%. It comes to around 84. And the PG won 3 out of 4 medal prize exams in the end of year 3. So all the outcomes she has shown that she has achieved, more than achieved. So strongly recommended. It was not individual whims or fancy. But the deanery informed varsity that rule is a rule and enforce 6 months extension. If you are the head of department, what will you do? You have to introspect. So compassionate pedagogy indicates that you advise PG to seek justice, because I can't push for justice. Only they have to go for legal redress. So that person filed a case, and as it turned out, the law ruled in PG's favor, and the person passed without losing 6 months extension. So sometimes you have to do this in terms of compassionate pedagogy and compassionate leadership. Sometimes you have to face up to the martinet. Another one martinet is no leave for next 6 months, because we expect surprise inspection anytime from July to December. You say like that, you notice staff distress, and what do you do? Then Solomon cap, that's what I said. You put Solomon cap and think, after all, inspection is 2 days only. So for them coming that inspection team coming anytime, it's only 1 in 180. 180 days, 1 day they'll come. So, and they'll anyway be there 1 more day. So how to mitigate distress? I was given the permission to grant leave on specific needs. So every leave I could grant, because they said they'll be able to come on 2nd day of the inspection for head count in case it happened during the leave of absence. Only one person out of about 120 who wanted leave at that time they couldn't guarantee, so I refused that. Otherwise, the remaining 119 or something, except that one, I gave all the rest. And finally, no one was absent when inspection actually happened. So sometimes lack of understanding causes this kind of fear psychosis and a very kind of rash response. But if you can't convince them, then best is you take the courage and responsibility on you and do what is compassionate. The lesson learned for me is always wear a Solomon cap before giving up and try to find win-win solution. And all this is needed because when we show compassion, our graduates become compassionate. So we have to stop being a negative role model. The first shock interns get, I also got, name calling by clinical specialist. Oh, he's a butcher. Oh, he's a gas passer. No, that kind of thing between surgeons and anesthetists and all that. You are shocked. Such a respected teachers of previous year, final year, suddenly start bickering like children, in front of operating room and all that, and affects our own professional identity formation. So many of us would have faced that, but for our students to become more compassionate, we should become positive role models so that they go beyond professionalism to humanism. Professionalism is what we do and can be undermined when no one is watching. But humanism is what we are. If you are a compassionate person, it will be compassionate whether someone is watching or not watching. I'll just give one example before closing. Acute schoolboy with acute knee injury, here only, from near 1 kilometer away, there is a primary school boy got some football injury and teachers brought him with a swollen knee. So ortho team immediately came and rushed him to operating room. This is a story of 1972 to attend to the acute bleeding and hemarthrosis. So that was professionalism. But an intern who was actually not in ortho, he was posted in OG or some other posting, was sitting waiting for a case. Then mother and parents came and they said, student, your son is an OT, his teacher has signed consent form, you sit here and you will get the news. He will come here after surgery. Then the mother started lamenting, Upari, they start crying. It's called dirge, D-I-R-G, dirge or Upari in Tamil. So ritualistic crying, and said, my son used to get, whenever he gets a small injury, it swells like an idli and all that. She was very figuratively describing. And while waiting for the case, this intern realized that it was probably a case of some hemophilia or something. So he ran to the OT and alerted the surgical team. Mother says the boy gets slight injury also, big swelling and all that. So they checked the stuff, BTCT, and then it was turned out to be some hemophilia or some variant. So that is what I mean by professionalism and humanism. Beyond professionalism, humanism. So we can create at least 20 or 30% of our students in this mode, it will be good. So the take-home messages are a few. There are challenges which we face. How to balance compassion with academic rigor. It's called warm demander model. I'll talk in the last slide I'll show. And compassionate pedagogy, as I explained, is not zero stress and producing lethargy or removing accountability, but doing it in a non-judgmental, compassionate way. Protecting patient safety is much more vital than students wish to pass. That is also part of compassion. And there are a lot of studies showing the warm demander model achieves the best learning outcomes. It is not soft and fluffy emotional stuff like many people think. Compassion is not soft, fluffy, emotional. It's very effective, especially if it is a warm demander model. But there is a risk of commodification. If a medical council or somebody says compassion, excellence, framework, metrics, and then ask Dean's office to fill up for all the stuff, then it becomes ticking box exercise and not a genuine effort at compassion. So this needs a change of mindset and improvement in one's own adoption of compassionate pedagogy as applicable even to postgraduate and super specialist courses. And other challenges are neoliberal contests. These are other extreme, especially in private universities, private medical colleges, viewing students as entitled consumers. They paid their fees, so students and parents are customers and always right. That puts us as a very great disadvantage, creates a compassion gap. And unintended consequences. We have seen it during COVID time. We had a crisis in Jitmar also. No detriment policy. Then all this causes staff workload and fatigue and can result in compassion fatigue. This is a reality also. There are some studies about compassion fatigue in teachers and medical health profession institutions. The students can also get adversely affected. Perception of compassion can be seen as a weakness. That that teacher is very soft and fluffy. We can bug the class and not attend and all. Then misinterpretation of support as a pity. I have faced a student like that. I tried to help in Malaysia where she couldn't pay the fees, but she wanted to quit. I can't pay the fees, I'll stop MBBS. Then I suggested to her, just take they allow interruption of the course. Deferment. Take deferment on financial ground. I strongly recommend you're a good student. Things will turn and you might be able to come back. So what happened is she joined some multinational as pharma representative. She did such a good job. In 2 years, they gave her so much of bonus that she could come back and pay the fees. And then she also became very attractive and very well behaved. So somebody offered to marry her, a very rich person in her own community. So once she married in final year, then all the financial problems solved overnight. So things happen. So my only contribution was not accepting her quit letter and say make a deferment letter. So that came in very handy. She is a very prosperous, busy doctor in Malaysia. Confusion about boundaries. This, of course, compassion can be mistaken, and some people may think it as seductive remark or whatever. So we have to be very explicit and well behaved and both with explaining rules and norms to students and in our own behavior. When I was a dean, the 2 doors will always be open and one door, my PA will be sitting. She was a lady sitting directly watching me. So she was my protection. So we have to mark our boundaries and also remain safe and beyond any suspicion. And sometimes when we show compassion, they say you are not empowering. So warm demander model is empowering model, and fragile students sometimes complain and not really try. So we have to convince the parents with evidence. Nowadays, drone parents and helicopter parents will come and accuse the college and the teachers. If we have enough evidence, then we can show. I remember this time in 2021 or something, no, 2019, one parent came and said, my daughter failed by only 2 marks, 3 marks or something. Can't you adjust? How can you fail her? And she, a retired army man, started shouting, and the vice chancellor was very scared. Then he called me. I went and told him, you think the first guy, first rank was 96% or something. I showed him, see, 96% people have scored. Do you think they're all fools? We have 100 marks. She couldn't even score 50, and you want to fight why 2? She didn't lose 2 marks. She lost 52 marks. Don't say 2 marks failure. It is 52 mark failure. You are supposed to get 100 out of 100. So when I put it in the reverse way, his face changed. In the end, he actually apologized, shook hand of vice chancellor and everybody and said, please take care of my daughter and make sure she passes and all that. Of course, she passed next time. But what I mean is, we have to sometimes convince parents with evidence. And of course, giving a long rope may sometimes backfire. Ideal is when they use it to climb to the top, like the student who we gave student loan and is a very prosperous practitioner. Some misuse it for fun, and some get entangled in whatever compassion ground we give. Ultimately, hang oneself, hang on, not commit suicide. I'm not meaning that way. Figuratively. Example, helpful hint in the exam. If you give the hint, it should be worthy of the student. It will backfire if the student is ignorant. They don't know anything. You go and say, this case of mitral stenosis, they'll go and say all wrong murmurs and say the diagnosis is a mitral stenosis. Then they'll definitely fail. Another case I remember, when I was a student, we went to MMC for anatomy. There was a compassionate skilled assistant. He told the attender, you tell the structure which you are giving for staining. So they gave elastic fiber for staining. But the attender was told to cut ligamentum nuchae of some animal and make pieces and give students. So he doesn't know. He's just an attender, fifth standard pass or something. So he came and told everybody ligamentum nuchae and went. So those of us who have studied, we took it as a hint, and then when we saw elastic fiber, we were happy and said elastic fiber. Example, ligamentum nuchae. But the people who didn't know anything, they all said ligamentum nuchae. They never said elastic fiber, and the examiner got wild, and all of them were given 0 and sent off. So that's what I mean by hang oneself. So we have to beware. We show compassion, but we have to also know the scene when people can get climb to the top with that, like that auscultation blind deaf person who is a very successful non-clinician, like that. There are some people who need help. So compassionate pedagogy is an action concept. Use stress as the best learning outcome, and our job is to reduce distress to eustress, and not our aim is not to give 0 stress situation. And we need conviction to execute it and courage to face the consequences if you want to be an umbrella type of leader in your own field. And sense of coherence achieved from understanding, coping strategy to manage, and finding the option meaningful helps us to mentor the students. And compassionate pedagogy leads to compassionate healthcare professionals as our graduates, and that's what we desire to get. So all this was theoretical, but we got proof when Shivashakti, she is my prime mentee in medical education. We did a doctoral level conative action research on supporting students needing additional curricular support. The so-called low achievers and problem students, we call them snacks, students needing additional curricular support. And it was, we didn't know the term. So probably Shiva and I will write a paper on this now. It's based on warm demander model. High expectations from the students, warmth and support, unconditional support, scaffolding and support based on solid pedagogy principles, and belief in student potential to get through and shine. And finally, most important, teachers' self-belief in molding the student, that I can mold the student to something useful later in life. So my plea is, let us be compassionate, warm demanders to achieve the best learning outcomes for our students. And I thank you for a very patient listening. I planned it for a 60-minute talk, but I took much longer. I hope it was worth it, and at least I enjoyed it. Thank you very much.
Thank you very much, sir. I come from a specialty which demands from the students and doesn't give anything back. I'm a cardiothoracic surgeon. But listening to you, I think that I can give much back to the students, especially with this many of 170 odd people who have assembled here, and their chat box is full of what you have taught us. It's a wonderful feeling. Thank you very much. It was a truly enlightening and deeply moving presentation on compassionate pedagogy, of which I had heard only a couple of weeks back. As we strive to move our students from paradigm of suffering towards authentic humanism and professional life, this is something which I had written down, but that is not it. It's really what you have to do, and everyone in this room will have some expression of compassion that they have shown or they have received, and that truly is what we expect as we uh, set our eyes on this inaugural webinar. And it sets a powerful and inspiring tone for the year-long Golden Jubilee celebrations of NTTC. Sir, your legacy continues to inspire generations of educations, and as your contribution today was once again enriched by our understanding and what it truly means to be transformative teachers. And especially, you are walking the talk. You are producing a paper out of this subject means we, all of us, have to strive towards something greater. Thank you very much. Now,
Thank you.
now as we move on to the question and answer session, I see that we have one question on the Dr. Rajalakshmi, would you like to?
Yes, sir.
Rajalakshmi is supposed to handle
Yes,
Q&A.
sir. Yes, sir. So there are a lot of words of appreciation. So I think you can see that in the chat box, but I'll go to the questions directly, sir. So this is a question by Dr. Ankit Chandra. The question is, one kind faculty can mentor only one student. For mentoring more students, we will need more compassionate teachers. So madam is asking, or sir is asking, how did sir use to motivate other faculty members for mentoring and being kind to students?
No, these are just shown, demonstrated, and if they ask, we can explain.
Okay.
So sometimes, yeah, I don't know. I've never taken a formal FDP or a CME on compassionate pedagogy or importance. This is the first time. Maybe it should be done more often. When I see some crisis in different colleges, maybe it was in my mind somewhere, and suddenly it came up while during sleep. I told you, my talk was the need for generalists versus specialists in 21st century. That was a topic given, but I thought that was a more policy-oriented matter. I'm not qualified to talk on that. So
there's one more question from Dr. Chandru Parivarmal. Sir says, it was always a pleasure to listen to your talk, sir. Sir has a question about students with mental health issues that have cropped up after COVID. How can compassionate pedagogy be effectively extended to this cohort of students? And we in Edinburgh have students with ADHD, autism, and the spectrum getting exceptional support during exams and during their education. Is that the same in your experience in Malaysia?
no, in Malaysia, it's very strict. The dean is held responsible if you admit a schizophrenic or a heavily autistic, in the spectrum, extreme form of the spectrum where they are cannot, in the words of the medical council, unfit to practice patient safety reliably. So we are supposed to do. So ever since I joined, I think we have, from 2006, we have a panel to check the English, because English is medium, so we have to check English proficiency. Then 2 stations, 5 minutes, 2 psychiatrists, 1 counselor and 1 psychiatrist will assess the student. And whenever some red flags are raised, we'll send them to government mental health department to get a clearance. And once they give clearance, then private university, we are safe in admitting them. But some of them will not come back. So they are obviously unfit. So we have a thing of weeding out mental health cases. Even then, 1 or 2 who were borderline and we miss it in the screening. Later, when they have this one now, love failure, then such things what I call as individual critical juncture pushes them down, and they become problematic. So I faced one or two like that also. And when they become interns, then they send a query, how you missed. Then we have to send an explanation.
So there's one question from my side as well, sir. So as individual educators, we can actually model compassion beautifully, sustaining it across the entire institution. But doing it at the institution level, I think it definitely requires a culture shift as such. So how can this compassionate pedagogy be institutionalized, not just practiced by individual faculty?
See, when I was a dean for 12 years in Malaysia, that is the experience I can share. I said, we have to show compassion to students because they are also fee-paying private university. So, and any problem case you send to us, to dean's office, and I had time. I stopped teaching. I stopped seeing patients. All my time was only for students and staff. So somebody has to devote the time. So my door was always open, no appointment. People can come anytime, no appointment at all. So that is how I operated. And as I said, wear a Solomon's cap and think. And usually you can solve. Usually you can solve most of the problems if we set our mind. And once we, supposing head of the department has done some thing that a student is complaining about, then a three-way cup of tea and then call both parties, sit together and sort it out. Then it becomes all right. So that happens. There was a postgraduate who was so bad. Nobody wanted to be his guide. Then he said, I paid my fees and joined. You have to give me guide. He started putting pressure. If nobody wants to, it's a physiology department only. Nobody wanted to be guide, and because he was problematic. And I told him, what to do. Then finally, the same religion, I got somebody, and so at least religion-wise, they could go together. So they go to church on Sundays. The rest of the day, I tried to manage, and somehow we finished. So there are challenges.
Yes, sir. So there's another question in the chat box. Is there any method or technique that sir has found or tried to nurture compassion among medical students? Because evidence shows that compassion of medical students or doctors decrease with growing clinical years.
Yeah, that is the one I said. Compassion goes down clinical years because of this what they see in the doctors do. I showed some example now that how the way they shouted PGs or the way 4-letter words are used in operating room. We have all seen staff like that. In the labor room, very respected professors slapped women in labor. In fact, somebody was so traumatized. He rang me 2 days back. Student, he said, I got post-traumatic stress disorder. He was a student intern in 2000. So 25 years have gone. Even now, once in a way, he gets up with nightmares of somebody shouting at him in labor room and all that. So he said, I had a very traumatic time, and watching them rude to the interns as well as to the delivering women. So like that, there are pockets which are notorious for this kind of lack of compassion, because the nurses get compassion burnout. That's what is called compassion burnout. So the working norms must be in such a way that people get cool postings, not tough posting all the time, so that they have a time to recover the poise and come. So some kind of rotation must be done.
Yes, sir. So there are no further questions in the chat box. I request the participants to unmute and then you can ask your questions.
Maybe if there are one or two from Malaysia, so a bit late for them. Going to be 11:15. I don't know if anyone is there. Or I think Professor YD Singh may be there. He might say something.
Oh, the Malaysian Christina here.
Hmm.
Yes, sir. All the anecdotes, some of them I had known them also personally from because working with you for it's an awesome session, sir. Yeah, really nice, and so we are motivated to be better, compassionate teachers listening to you. So we still have a scope to perform better. Thank you, sir. We do face all the cases that you said, so that's what I just want to say. Thank you, sir.
I think somebody has asked a question in chat box.
They've asked, can emotional intelligence of faculty and students contribute to compassionate pedagogy? If so, how?
Yeah, definitely. EQ is emotional quotient is probably a good way of training people to become self-aware and manage relationships and all that. But the conative domain has to be there. It may emotional quotient I didn't touch because it goes into sympathy, empathy, that part. But here conation is needed. If you want to show compassion, you have to act to mitigate the distress. Simply showing empathy is not enough. So it goes beyond empathy to conative action. Goal-directed
May I,
action
ma'am?
to mitigate distress.
Yes, ma'am, please.
With my mentor's permission, sir, I would like to add a few points for the two questions that was asked to you. May I,
Yeah,
sir?
please tell, you are my memory bank always, so please go ahead.
Yes, sir. That one question on ADHD and autism-related students in Edinburgh, they are facing with. The same question was posed to me when I presented this snacks as a workshop for the ME conference. And that time only they told that the other training that we are giving to the faculty here in identifying the students and then to support the students, I think it is echoing.
Hey, you got two devices, I think.
Not
Echo
me,
is
sir.
coming.
Not me.
Okay. Carry on.
Is it echoing now?
No, stopped.
Yeah, thank you. The issue thing is, sir, the way that we told them to identify the students.
You're not audible now.
Yeah. Madam has lost
No, somebody is keeping on muting me. Okay. And the second question is related to the institutionalization. Ma'am, that is from snacks, we have now come to the level of FEET, that is the faculty empowerment for academic training. What started as a PhD project with Sir, the lessons learned from that has been translated into a policy document or as a standard operating protocol for identifying and supporting the students needing additional curricular support, as well as the students provided with enriched curricular support. And a training program is conducted for all the constituent units of the university. And on a routine basis, it is being followed up. So I think it is up to the faculty members, even one or two members in each institution is interested. Definitely, it is possible to inculcate this and institutionalize it. Thank you. Rajlakshmi, ma'am, you are muted now.
Thank you, ma'am. Thank you for sharing your thoughts. Dr. Nirmal, over to you.
Thank you, ma'am. Sir, I had a question. By the way, your talk was amazing, very different, and I'm so glad that you decided to speak about this today, especially because you say it was not something you decided. My question is that, your talk largely focused on how we can, when we teach, how we can be more compassionate. But like you mentioned, there's someone who's still suffering from PTSD even 25 years later. Many of us may be in that same situation, right? So maybe including me or someone I meet. When I hear that, oh, those days were torture, the teachers were so bad, they were not empathetic. How do we, what do we talk to ourselves to sort of, get over that and be normal again? That's not my mic.
Compassion.
I've muted myself.
Oh, your question is very, very challenging to answer in such a simple way, but if I am suffering from, if I had had bad experience when I was a medical student, and then what happens means we have to be resilient. So that is where that emotional quotient and emotional intelligence helps to come back. Otherwise, we have to go for counseling or I got a very good grounding because when I was doing MBBS, that is the time Eric Byrne book came.
Sir,
Games
could you please
Play.
mention the name of the book again?
Games People Play. It's available.
Okay.
You can download Games People
Right,
Play by
right.
Eric Byrne.
Okay.
So that was on transactional analysis, that every mind has got adult, child, and parent, adult, and child, and how the interactions cause cross communication and all the trouble and all that. And all the problem behaviors he explained. And later, Thomas Harris, his disciple, wrote a book called I Am Okay, You Are Okay. So they were my kind of Bibles. I read it several times, internalized, and then not that I didn't have challenge. On psychiatry person, when I was 10 minutes late to attend a seminar or journal club or something. I was posted from medicine and there was some cardiac arrest. We finished and went. Without even finding out the cause, she started ridiculing me. This is what medicine people think, how they talk of other specialists. Anesthetist is fired by a surgeon, then psychiatrist similarly will fire physicians. So she started stereotyping and down. So I didn't know what to do. I have this thing of calmly looking at her, and she became uncomfortable after some time because I didn't show any reaction. I stood like a stone and looked at her. Then after 5 minutes
That's
of
commendable, sir,
talking,
but not something that many
no,
of
but
us would
today
do.
only I saw in YouTube that is supposed to be a very effective way. You be
It
so
is, sir.
calm that
It
others
is.
become
You have
nervous.
to
That is
practice.
the title.
That's
You
right.
you
That's
can
right.
see in YouTube, be so calm that others get nervous. That is the title of the 10-minute video. She explains how Navy SEALs are trained to be so calm under all circumstances. I didn't know that. I saw the thing only today. But somehow
So
instinctively I said
this
best is
leads
not
me
to
to
react.
another question. This leads me to another question, ma'am and sir. I hope it's okay. So like you said, you quoted somewhere that you learned something from the business world, right? Like some of the things like the umbrella
Yeah,
versus the
umbrella and
wire.
funnel
You
leader
learned
and
it from
umbrella
business.
leader.
My
Yeah.
question is, we are dealing with people all the time. We're dealing with vulnerable people all the time, and as doctors, we are always challenged physically, mentally, emotionally.
Mm.
We are not making millions of dollars, right? So even financially, we are always just about okay. My question is, why is our syllabus not including these kind of topics like compassionate pedagogy, being kind to one's own self? I feel like you are in a position of power where you could influence the syllabus, which is why I brought this up.
No, I'm not. I was never involved. 97 curriculum, we were actively participating at that time. 1997 curriculum. After that, I'm far removed from medical council. So, but the problem is compassionate pedagogy means in 8th module, one more discrete thing will be made, and the anatomy lecturer or pharmacology professor will be asked to teach. That kind of prescription doesn't work. So we'll be only ticking the boxes. Nothing real will happen. So we have to embed in the curriculum itself.
We really
When
have to embed it in the curriculum and
the
make it a
curriculum means
really
when every case that
robust
is
part of it,
discussed,
sir. So, for
every
example,
bedside case. Yeah.
like at IIT, they are studying, they're studying humanities, they're studying philosophy. And I was so surprised to hear that, they could take that as optional subjects. And I'm like, as doctors, we are not even taking any optional subjects like this or compulsorily. We're not being taught how to communicate with our patients, in very difficult situations. No one is actually teaching us that. Because I mean, someone who's good, a moment they may take to teach you, but it's not a compulsory course, and I think it should be.
Yeah, true. No, not a separate course. I would say embedding the elements. You train the
Yes,
teachers
that's
so that
actually what I mean.
Mm,
Yeah.
yeah. In
So we
my
have
I feel it would go a long way in making us resilient as well, because a lot of us enter college at 17, 18, and we are sort of stretched thin in every way.
see,
So I-
Solomon Cap kind of win-win-win works in many ways. I showed only one example, that acute hemarthrosis, to show humanism. And humanism often means finding this win-win-win solution. There is a lady from 20 kilometers away. She couldn't afford the bus fare, so she will walk, start in the early morning and reach by afternoon. And then they'll refuse to give her K sheet because she has come late. And then she will come to casualty and they'll say, you are not an emergency, you come tomorrow. Come tomorrow. So because all are acting by rules. But then she was I was treated once in the ward. So the minute she sees me, she will catch my leg and say, I will not go, you have to give. So I will take her inside a casualty, emergency ward, and give her treatment and all that and go. And that was happening repeatedly. Then I told her one day, why don't you take a job outside the hospital, so that she is asthmatic. You can come anytime you want and take emergency treatment. You don't have to walk with asthma all the way. So then she was a rag picker. So here bottle sales plenty. So she got this thing. I'll become bottle seller. So those days they'll bring bottles for syrup mixtures and all that. So she also set a small pavement sales of bottles, and she earned enough to support herself and sleep in the platform like so many others. And then she will come and take injection whenever she needed. So sometimes we have to, I didn't give any 1 rupee from my pocket. All I did was listen to her and suggested, why don't you get a job here instead of picking rags in 20 kilometers away. So like that, for each one, we have to wear a Solomon cap and think what is a solution. There is no single formula for solving everything. We have to see that's why the sense of coherence is the only formula. Understand the situation, find several coping options, that is manageability, and whatever is most meaningful, let the client choose. So this patient chose bottle selling the bottles in front of the hospital as a sustainable option. It worked until she died about 6-7 years later. Till then, she was always on the platform selling bottles and taking treatment.
Got it, sir. Thank you.
Yeah.
We have a couple of
Hello.
questions. So we have a couple of questions. So the question is, with the advent of artificial intelligence and other disruptive technologies, the face-to-face session as well as proper coaching sessions are getting reduced, as they have created technology-based support systems with minimal human presence. How do you go about it, Professor? Dr. Sundaram from Malaysia has asked.
No, we can make the prompt in such a way that that compassionate scenarios, the case scenario needing compassionate handling can be built in. So it'll if you give 1 or 2 examples, it will create several examples. I have done that also. Already in ResearchGate, I have put up some. I can make several more and put it up. So it is possible to train the AI to think in our lines and train the students. So then we don't have to explain. Actually, that answers the question others asked, how do you make it institutional? So one teacher can generate a AI prompt after tweaking it properly and giving some example in, let's say, internal medicine. Then the same prompts can be used for surgery, ONG, anesthesia, ENT, ophthalm, everything. And it will work. And you can just correct it and make it happen. So it is possible.
Okay, sir.
AI is a tool rather than a block. That's what I feel.
Yes, sir. And now, very personal question, sir. How did you learn to deal with such varied experiences in life? Did you have mentors who really influenced you to be so emotionally prudent and compassionate?
I told you my mentor was positive role model was Dr. Ganeshan, and appreciative inquiry and always supporting the student is Professor Chandrasekhar, my guru, professor of medicine, and who was also director of JIPMER. Always positive. He'll every batch he'll say, "You are all shining students. You will do very well. Don't worry," and all. They'll never talk bad of people. So he was very supportive. Then, of course, the psychologists, Eric Byrne and Thomas Harris, they trained my other part, critical thinking. And of course, Solomon's story came in very handy for problem solving. So I trained one. Another thing is when you live past the mid-70s, then you have, I started internship in 1972. So 53 years. So a lot of experiences, and you learn from each one. Some positive experiences, also negative experiences. A student committed suicide in 2019. I'm still very tragic, because anatomy exam was there. Parents forced to study, he jumped. And then the dean and everybody else gets the flak. So only thing we hadn't done is curriculum in year one was still tough. So I took a thing before I leave and AIMS, I'll dilute the stress in year one and distribute it to year one, year two. That was done. Now year one is only foundation 6 months, year two is 18 months, and exam is after 24 months. So I heard that it's working very well. I wasn't there to see the result, but I am given feedback that it is working well. And all the high failures in anatomy and biochemistry are thing of past now. So it is possible to do, but I wish I had done it before and not after the student jumped.
Thank you, sir. Thank you for that. One last question from Professor Dr. Tanushree. Over to you.
Yes, thank you. Thank you very much for this powerful and, insightful, thing that you had provided us, sir. Sir, one thing is that we are talking about, compassion to the students. How did you deal with those problematic faculties who, in a way, influenced badly on students? What is your message regarding that?
Students, we had a redressal mechanism, so we just report and they take action. And the thing is, in Malaysia, the situation is different. So it will take time to explain. What I can do is, I'll give my email, krsraman@gmail. It's very easy to remember. krs.raman@gmail.com. So any queries, you please feel free to send. I'm retired now, sitting at home. I can send a response. krs.raman@gmail.com. Whatever query you want, any resources you want also, you can ask. I got pedagogic material from 1988 onwards I've collected. So in case I have anything to share with you, I'll be happy to do that.
Yes. So thank you very much for this very wonderful session. And now we come to the end of session. Thank you all for your engaging questions and active participation. This concludes the inaugural webinar of the NTTC Golden Jubilee celebrations. A heartfelt gratitude once again to Professor K.R. Sethuraman sir for inaugurating this milestone celebration with such wisdom and grace, and to our director, Dr. Veer Singh Negi sir, for his visionary leadership and unwavering support to NTTC's mission. We also thank our Dean Academic, Dr. Vikram Kati sir, faculty, guests, and participants from across the globe for making this event a grand success. Details of upcoming Golden Jubilee events will be shared shortly. Please stay connected with us throughout the celebratory year as we continue to honor the five decades of excellence, innovation, and compassion in medical education. Thank you all once again and have a wonderful evening.
Rajalakshmi, just 30 seconds for Dr. Y.D. Singh.
Sure, sir.
He is Yes, Prof. YD Singh, I requested you long back. So,
No, I was can you hear me, sir?
yeah.
It's a wonderful experience to listen to you once again after such a long time. I could relate to some of the experiences you were sharing from Malaysia because I was there as professor and head of the department for about 5-6 years. You know it under your leadership, and we had many difficult situations, and with your guidance, we were able to. We were able to overcome all of them using all the techniques which we have discussed today. And it has been a wonderful learning and a wonderful journey actually serving under you there. And we are trying today, I'm still professor of medicine now here in Pune in one of the private medical colleges. And I use these techniques. I find that somehow interest in education, medical education is falling. Students don't come to face-to-face classes also now. So it's very difficult to motivate them to come to the classes and all that. There are multiple factors over there, how to create interest in all that. So we use all these techniques which we have discussed and create in a very compassionate manner. We talk to them and hope that the situation improves. Thank you very much for enlightening us with your personal experiences and all that. They're very motivating, sir. Thank you very much.
Thanks a lot. Thanks,
Thank you.
organizer, for allowing one more minute comment.
Yes,
Yeah.
sir. Thank you very much, sir. Thank you, sir. Thank you,
sir.
all participants. Thank you. Good evening.